Gender dysphoria is characterized by persistent discomfort with one's own sex, causing significant distress and a persistent cross-gender identification. Some terms to be familiar with include transsexualism, where people have the desire to live as the opposite sex, often taking on surgery or hormone therapy to change themselves into the opposite sex. Transvestism describes wearing clothes of the opposite sex. So you can keep these two straight by remembering that transsexualism includes the word sex, so they're actually trying to change their sex. And transvestism involves clothing only, and it contains the word vest, which is a type of clothing. Sexual dysfunction is a general term including sexual disorders such as sexual desire disorders like hypoactive sexual desire or even aversion to sex, sexual arousal disorders like erectile dysfunction, orgasmic disorders like anorgasmia, which is an inability to have an orgasm, and premature ejaculation is also another type of orgasmic disorder. There's also sexual pain disorders, which include things like dyspareunia, which is pain during intercourse. Also, sexual pain disorders include vaginismus, which are painful contractions of the vagina upon penetration. Causes of sexual dysfunction can include things like drugs, such as antihypertensive, neuroleptics, SSRIs, and ethanol. Diseases can lead to sexual dysfunction, such as depression, diabetes, and STDs. And lastly, psychological factors like performance anxiety can also cause sexual dysfunction. Sleep terror disorder is characterized by periods of terror with screaming in the middle of the night. This usually occurs during non-REM sleep. So there is no memory of the nightmare after waking up. So no memory of the arousal and the nightmare because it's occurring during slow wave sleep. The causes of sleep terror disorder are unknown. However, triggers include emotional stress, fever, and lack of sleep. Now keep in mind that for the exam, the disorder is usually self-limited and resolves over time. So if the question asks you for what should the treatment be, it's not going to be treated with drugs. It's usually just going to be waiting for it to resolve on its own. Narcolepsy is a disorder characterized by misregulated sleep-wake cycles. This leads to excessive daytime sleepiness. Is caused by decreased orexin production in the lateral hypothalamus, and orexin is a neurotransmitter that regulates arousal, wakefulness, and appetite. Narcolepsy is associated with hypnagogic or hypnopompic hallucinations. So, which one occurs when going to sleep? Hypnagogic. Remember the go for going to sleep. And which one occurs just before awakening? The hypnopompic. Remember, pompous upon awakening. Now there can be narcoleptic sleep episodes, and this is where a person rapidly falls asleep, and these start off with REM sleep. They're immediately in REM sleep. Patients also have cataplexy, which is loss of all muscle tone following a strong emotional stimulus such as laughter. There is a strong genetic component to narcolepsy, and treatment includes daytime stimulants such as amphetamines and modafinil. Nighttime treatments include sodium oxybate or GHB, which helps patients get restful sleep during the night so they don't have excessive daytime sleepiness. Flash quiz blank. Transsexualism or transvestism is the desire to live as the opposite sex, and transsexualism/transvestism is the desire to wear clothes of the opposite sex. So remember that transsexualism is the desire to live as the opposite sex. Live as opposite sex. And transvestism is the desire to wear clothes of the opposite sex. And both of these are a type of gender dysphoria. Substance use disorder. This is a maladaptive pattern of substance use with 2 or more of the following signs in 1 year. Those are tolerance, which is the need to use more of the substance to achieve the same effect, like a high effect. Withdrawal, when stopping use of the substance. Taking the substance in larger amounts than what is desired, or over longer time periods than what is desired. Persistent, unsuccessful attempts to cut down. The person keeps on trying to quit or cut back, but they're unsuccessful. They spend significant energy obtaining and continuing to use or recover from the substance. There is reduction in important activities such as social, occupational, or recreational activities because of the substance use. The person continues use despite knowing the problems that the substance causes. They have cravings. There's recurrent use even in physically dangerous situations. Failure to fulfill major obligations at work, school, or home due to substance use, and interpersonal conflicts related to substance abuse. So if someone has 2 or more of the following signs in 1 year, they have substance use disorder. Let's talk now about the progression of the stages of change in overcoming substance addiction. This is a very wards relevant fact and offers a good way to conceptualize the counseling process for patients suffering from drug abuse. It's also great for tracking your progress when you realize caffeine has too strong a grip on your life. The first phase is called pre-contemplation. Pre-contemplation. This is where people are not yet acknowledging a problem and are truly not interested in quitting their substance, like you and your caffeine. Now, historically, most attempts to do drug abuse counseling have failed in patients who are still in this pre-contemplation stage. You have to get them into the contemplation stage, where patients will acknowledge a problem exists, but are not yet ready or willing to make changes. So right now I'm trying to get you into the contemplation stage with your caffeine use. So the third step is preparation and determination. And this is where people start to think about how to prepare and become motivated to actually undertake the process of quitting the substance use. Then the fourth stage is the action or willpower stage, where behavioral changes actually start being embraced. The person starts actually making changes in their life. From here, the patient will either continue to maintain their cessation of drug abuse, and this is called the maintenance phase, or if they relapse and start using the drug again or substance again, they go into the relapse phase. And once the patient relapses, the cycle has to start all over again. back to the contemplation phase and back to going through new preparation and new determination, taking on a different strategy to quit the substance use. Now, it's common for patients to go through these stages multiple times before patients can effectively maintain their new behavior. And sometimes that just has to do with finding an effective strategy for the patient. Let's discuss now psychoactive drug intoxication and withdrawal. This is a very high-yield topic for the boards. It's important to remember the key signs and symptoms you see from abuse of a drug. And oftentimes, you'll see the exact opposite effects when the patient undergoes withdrawal from that drug. Now, generally speaking, when people abuse depressants, like classically alcohol, they'll experience decreased anxiety, mood elevation, behavioral disinhibition, and respiratory depression. Withdrawal, you'll see almost the exact opposite: increased anxiety, tremor, seizures, and insomnia. This makes sense because these are basically the opposite of the effects of a depressant. And what we're doing in withdrawal is removing that constant exposure to a depressant. Now, the first example, alcohol, that we just talked about, is probably the most boards and wards relevant example you'll see. Abuse of alcohol leads to emotional lability, slurred speech, ataxia, coma, and blackouts. The serum gamma-glutamyl transferase level is a sensitive indicator of alcohol use, and liver function tests, which are looking at the AST and ALT, will show that the AST has twice as high a value as the ALT. Now, withdrawal effects are similar to the ones we mentioned above for general depressant withdrawal. However, with severe alcohol withdrawal, patients can have life-threatening delirium tremens as well as autonomic hyperactivity. With opioid intoxication, patients have euphoria, respiratory and CNS depression, decreased gag reflexes, which can be dangerous if a person were to pass out and vomit while intoxicated. They'll also have pupillary constriction, which is a classic sign of opioid use, and seizures during an overdose. Withdrawal from opioids causes sweating, dilated pupils, piloerection, which is the standing of the hairs on the body, fever, rhinorrhea, yawning, nausea, stomach cramps, and diarrhea. Barbiturates, which are more like dangerous versions of benzodiazepines, have a low safety margin. They can cause respiratory depression during intoxication, and during withdrawal, they can cause delirium and cardiovascular collapse. Benzodiazepines have a greater safety margin than the barbiturates, but they still cause ataxia and minor respiratory depression during intoxication. Withdrawal causes sleep disturbances, depression, rebound, anxiety, and seizures. When you think about treatments for drug abuse and withdrawal, remember this basic fact. Drug abuse is treated with antagonists. This is because the problem is that patients are experiencing drug toxicities. An antagonist will diminish the effect of the drug at its receptor site. In contrast, withdrawal occurs because the body is in need of the drug to work at its receptor site. Therefore, withdrawal is often treated with agonists. So pay close attention to specific treatments if they're described. For example, flumazenil, a GABA antagonist, is a treatment for benzodiazepine abuse. And this is classically tested on the boards. So, flumazenil, which is a GABA antagonist, is going to be used for treatment for benzodiazepine abuse, which are activating the GABA receptors. Now let's talk about stimulant intoxication. So, stimulant intoxication causes mood elevation, psychomotor agitation, insomnia, arrhythmias, and anxiety. Withdrawal will cause the opposite effect, a post-use crash, depression, lethargy, weight gain, and headache. So what are some of the stimulants? First one is amphetamines, which with intoxication cause euphoria, grandiosity, sympathetic hyperactivity, anorexia, paranoia, and fever. With severe abuse, patients can have cardiac arrest and seizures. Withdrawal leads to anhedonia, increased appetite, hypersomnolescence, and existential crises. Cocaine intoxication causes impaired judgment, pupillary dilation, hallucinations such as formication, which, if you remember, is the feeling of ants crawling over you, paranoid ideations, angina, sudden cardiac death. Cocaine withdrawal causes hypersomnolescence, malaise, severe psychological craving for the drug, and depression or suicidality. How about caffeine? Intoxication leads to restlessness, increased diuresis, and muscle twitching, and withdrawal leads to lack of concentration and headache. So, if you're taking a lot of breaks, using the bathroom while you're studying for the USMLE, you may need to cut back on the caffeine. What about nicotine? Well, we all probably know someone who smokes cigarettes, so this might be an easier one to remember. Now, what are some of the symptoms of nicotine intoxication? Well, the big one is restlessness. And if you think of a chain smoker who hasn't had access to cigarettes for a while, that withdrawal is going to lead to irritability, anxiety, and craving for the cigarette. So just think of a chain smoker who hasn't had a cigarette in a while. As you work your way through this list, pay particular attention to distinguishing traits of each drug. You'll notice many aspects of depressants and stimulant abuse have some overlap. Therefore, you should remember those effects, but don't count on them as being helpful to determine which specific drug toxicity a patient is presenting with. Look for the distinguishing features of drugs. For example, there's only one drug on this list that will classically present with angina, and that's cocaine. Angina with cocaine, because it's a potent vasoconstrictor. Another easy thing to keep in mind is what happens to pupils. Particularly note the two stimulants, amphetamines and cocaine, which cause pupillary dilation. So, cocaine causes pupillary dilation, and so do amphetamines. Pupillary dilation. Now, remember though, on the other hand, that opiate abuse leads to pupillary constriction, and opiate withdrawal will lead to pupillary dilation. Keeping things straight will take some time, but it's important to find these distinguishing characteristics and use them in a way you can easily remember. There's three that you'll need to know for the boards. The first is PCP, which is commonly tested because it's known to cause very aggressive behavior among abusers. They have belligerence, impulsiveness, causes fever, psychomotor agitation, analgesia, nystagmus, tachycardia, psychosis, delirium, and seizures. So, a patient who gets caught in some sort of illegal situation such as assault, you can think of maybe abusing PCP. As a fun side fact, Baltimore and New Haven, Connecticut hold the dubious honors of having the highest rates of PCP abuse in the country. Now, withdrawal of PCP leads to depression, anxiety, irritability, restlessness, and anergia, which is the lack of energy. LSD abuse is known to cause perceptual distortion, depersonalization, anxiety, paranoia, psychosis, and flashbacks. Now, it's symptomologically pretty non-specific for withdrawal, though. Now, marijuana intoxication, on the other hand, if you've ever seen the movie Half-Baked, leads to euphoria, sometimes anxiety and paranoid delusions, impaired judgment, social withdrawal, increased appetite, dry mouth, conjunctival injection, meaning the whites of the eye look red, and hallucinations. Withdrawal, on the other hand, causes irritability, depression, insomnia, nausea, and anorexia. Symptoms peak in 48 hours and last for 5 to 7 days. And marijuana is detectable in the urine for 4 to 10 days after use. So a patient presents with a respiratory rate of 8 breaths per minute, pinpoint pupils, and vomiting. The patient is most likely intoxicated with what substance? So the pinpoint pupils and depressed respiratory rates are a giveaway that this is opioid intoxication. The patient is also at risk for aspirating the vomit because opioids inhibit the gag reflex.